Okay, so the treatment-based classification that initially came out in 1995 was updated in 2007 and then updated most recently in 2015. This was the initial publication of the update in 2015, and it would mark the first in a series of publications that will come out that will follow the treatment-based classification on how to treat people with low back pain based off the system. One of the things that they did very well in the 2015 publication was outlining an algorithmic approach to treating people with low back pain. And so you can think of it more as a proper triaging to determine the patient that you initially eval and helping them navigate not only the medical healthcare system, determining whether they're indicated for physical therapy, whether you can simply provide them advice and send them on their way, and or actually implement their plan of care into clinic in determining which interventions they should potentially receive or that they're most likely respond well to. And so what I've attempted to do here is summarize the entirety of that workflow into a single PDF document. And so the purpose of this video will walk you through that process. So you can see that it starts with number 1, where it says triage by the first contact healthcare provider. And the authors denote that you should see figure 3. So I've put figure 3 off to the side here. And figure 3 is simply a yes-no algorithm that is a 3,000-foot overview of an individual within the healthcare system who has low back pain in the cycle that they will otherwise go through. It's not the primary focus of this PDF document, but it is there for your reference. You can read through it at your leisure. If, however, you are the rehab professional, then you're going to have 3 options for this patient. They're either going to be a medical management, meaning that they have red flags, medical comorbidities that preclude rehab, or they have leg pain with progressive neurological deficits and thus would benefit from seeing a neurologist and or orthopedic specialist. Rehab management, these are patients that we actually see and continue on with physical therapy. So they have medium to high psychosocial risk factors, low psychosocial risk factors with predominant leg pain, minor or controlled medical comorbidities. Okay, you can also note that there's a small red circle here that if you click on it or hover over it, that it will pop up saying, regardless of the approach, patients with medium to high psychological risk factor profile require psychological informed rehabilitation. This comes right out of the clinical practice guidelines that came out in 2012 by Delito et al. As you study for the OCS, this will be a component and something that you are otherwise exposed to if you haven't been already. This third column is the self-care management. So individuals that have low psychosocial risk factors, that predominantly axial low back pain, minor or controlled medical comorbidities. These individuals can be identified using the Start Back tool. So the Start Back tool is hyperlinked here. So you simply click on this, and this will open up a window that will take you to the Start Back. If you're not otherwise familiar with it, I'll show it to you in a moment. All right. So essentially it's 9 questions, agree or disagree, you give it to the patient, it's subjective in nature. At the end of it, you would tally up the scores and they would determine, based off the Start Back tool scoring system, the total number of scores and whether they are considered to be low risk, medium risk, or high risk. The medium and high risk are the patients that we continue to treat. The low risk patients are the ones that you give them basic home exercise program recommendations on good back health and practices and send them on their way. Okay, the other hyperlink that you have to help to identify your patients that fall into the medical management is E-Table 2 that was provided within this article. Again, it's hyperlinked, so if you hit Control and you click on the link, it should open up. Give it a second. Okay, there you are. Okay, so we're going to scroll down to table E2. So red flag medical management. This is also within the entirety of the lumbar eval lecture. This is just a one-stop shop for additional reference should you want to utilize this as well. So you got everything from pathological fractures and AAAs, kidney stones. It continues on to cauda equina, ankylosing spondylosis, central sensitization disorders. Okay, again, for your reference. Okay, we move on and we go to the triage by the rehabilitation provider. You've determined that they're in the rehab management group. Here you can see that this is information that is pasted directly from the article that helps to delineate the superscript subheading. So you have A, B, C. I'll scroll in so you can actually see. So you can see A, B, and C. I believe there's a D as well for psychosocial. Okay, so if you click on this or hover over it, it will give you the descriptions of those superscripts. So it's simply there for your reference. Treatment modifications, or modifiable variables. So the things that would modify your treatment would be the person's psychosocial status as well as their comorbidities. Additionally, you need to consider their irritability. Irritability, I think, is best described by Kelly et al. And J.O.S. Petit, though she was describing frozen shoulder and adhesive capsulitis. I think that it serves as a good reference. And so she identifies 5 variables that would consider someone to be moderately high or low irritability. So pain levels on average, consistent or resting pain, high disability, pain prior to the end range, active range of motion significantly less than passive range of motion would classify someone in the high irritability group. You have the respective information there for moderate as well as low irritability. Okay, if you're looking at comorbidities, if you click on this, it will open up what is known as the functional comorbidity index. So this is one of these the tools that was recommended within the article in the treatment-based classification triage, where you would be the one to fill this out, where you would go through and you'd click off the different indications. You can see that the score is telling at the top. You would hit next. You could see the total, and then the FCI score would be provided there. Okay, you can also, if you're interested in looking at the validity and the creation of this, it was done in 2005, and you have the PubMed reference just there. All right. So based off the patient's intake form that we have within our clinic, you can quickly stratify whether this would be a positive or negative for each of these components, or whether this would be a treatment modifier. Okay. For the treatment modifying variables, if you click on this, this simply gives you a layout of all the different ways at which you could track or objectively measure someone's comorbidity or their psychosocial status. These are not hyperlinks. They're simply here so that you have a ability to identify all the different measures and the ways that you can objectively measure these 2 factors. Okay, as far as the co-management approach, again, it's a hyperlink. If you click on it, it will open it up. Give it a moment. Okay, so same document as you saw before. This time it's referencing the 3rd table, and I'll show you that. Okay, so Here are the physical comorbidities associated with low back pain. Again, it further just delineates the different tools that can be utilized and the description of the tool as far as the scoring, highs, lows, MCIDs, etc. Okay. You'll notice that the psychosocial status does not have one of these blue boxes. However, if you scroll over to that 3,000-foot view, they are hyperlinked here. So if you click on any one of these, they will populate. For note, with the anxiety and depression specifically, in our clinic, we use the PHQ. And you'll notice that if I click on it, it'll be familiar to you. This is built into the Epic software. Little interest or pleasure doing things. Say they say yes, okay. Say they say 1, okay, 3 points, positive. And then you would continue with the distressed protocol and algorithmic decision tree that is built into our clinic workflow or wherever you're working beyond the residency. Okay, and then you have the FAPQ, Tampa kinesiophobia. Again, the psychosocial components can be broken down into 4 categories: fear of movement, pain catastrophizing, anxiety, depression, or simply depression. Okay, moving to step number 3. Okay, once again, you have the red circles. If you hover, it simply is there as a reminder, regardless of the approach that you choose. Medium to high psychological risk factor risk profile requires psychological informed rehabilitation. And so here you're going to identify the individuals that are in the symptom modulation group. They have high disability, high volatility, pain is high to moderate. Again, this is kind of you're considering your irritability as described in the chart previously shown. Within the treatment group, you can see that they've put this small symbol: rehabilitation must be modified appropriately to account for the patient's comorbidity status. Movement control, same components as the patient as the authors denoted this in each of the categories. The one thing you will know is that there's a blue box around each of these that would give you a further description. You can either hover over it if you want to read it, or you can double click on it and it will populate into a box for you. This is copied and pasted from the reference, from the article. Again, I tried to summarize the article into this single document for you. Okay. And then finally, the 4th step is the treatment classification and the decision algorithm. So it's written in an if-then kind of component to help to guide you through the symptom modulation, the movement control, and then eventually the functional optimization. So if you classify someone into the symptom modulation, then you would start with going through each of these questions. Is the patient irritable and inflamed? If yes, you need to address that first. Again, if you click on these things, they will open up an additional hyperlink. This is the same one that you saw before that further reminds you what irritability can be classified as, or the factors that can help to classify the patient as low, moderate, or high irritability. Okay, symptom modulation, again, this is copied and pasted directly from the article. So if you click on it or simply hover over it, it will also give you the information that you need. As the person progresses through the rehab tree, they'll eventually hit the movement control if things go as planned. And at this time, you can, again, if yes, then you would address the sensitization of the neurological structures. Otherwise, you would progress through each of these components. It should be noted that the functional optimization group is open-ended. This will be more individualized, and you'll get more specifics on this within the lumbar intervention lecture specifically. Okay, so that's the document. It's a single-page PDF. If you have any questions that come up, let me know. Otherwise, it should be, hopefully, relatively straightforward. But I did want to give you this tutorial so that you understood how to use the document.